So this is going to expand on some of what Dr. Andrew and Dr. Rowe talked about and maybe give a primer for some of the talks coming up. So when we think about next generation imaging or functional imaging with PET, I think the data we just looked at shows that it definitely more accurately identifies prostate cancer. But in terms of what the impact is or how we're going to use it, it's obviously limited by most of the studies being retrospective, often small, often single institution. But as we're seeing through the talks that were just given and through this talk, we're going to see the quantity and quality of the information is increasing, and more so the availability is increasing. So fluciclovine is widely available for some indications. PSMA is going to be widely available in the US soon. So what are like the overview of the clinical scenarios that we're going to be using this in? You could make some arguments about screening, but I think it's impractical, and so I'm not going to highlight that in this talk. But in terms of initial diagnosis of quote-unquote localized disease, for the favorable risk gentlemen, you'll have considerations on is this person an active surveillance candidate or not, or do they need treatment? For the unfavorable intermediate risk and above disease, you really want to know their accurate stage. Are they metastatic? Are they locally advanced? Do they have N1 disease? And then we'll talk about considerations in the biochemical recurrence, hormone sensitive space, and the non-metastatic castrate-resistant prostate cancer space. So as Dr. Rowe had mentioned, Dr. Andrew as well, functional imaging with PET can identify prostate cancer in the primary tumor. This is a well-done meta-analysis showing that about 90% of the cases you could see a PET positive PSMA signal in the primary tumor. That said, there's obviously ascertainment bias there, and was kind of hinted at. The PSMA, at least, is better at recognizing higher Gleason grade groups than lower Gleason grade groups. And that sort of discrimination may be helpful. Let me see if this pointer works. Yeah, that discrimination may be helpful. You could see that the accuracy for PET PSMA in a small study identifying Gleason grade groups 2 or 3 disease was about 0.91 versus about 0.57 for Gleason grade group 1. And in fact, the performance characteristics and the sensitivity of PET PSMA was better than a MRI read of PIRADS 4 or 5. And this sort of gives the idea that at least for some candidates where you're not sure about surveillance, or for some that you're thinking about focal therapy, there's many approaches that can be taken, but perhaps a PET MR would be able to identify occult disease that could then be sampled. And that's sort of the question that you'd have for your favorable risk prostate cancer patient. For unfavorable intermediate risk and higher, it's important to really know their stage. Are they metastatic or not, particularly as the landscape of how we treat hormone-sensitive metastatic prostate cancer is evolving, meaning that for anyone with hormone-sensitive metastatic disease, they're going to be benefited by intensification of therapy early. We see that in the STAMPEDE trial with abiraterone, or in TITAN and ENZAMET and ARCHES with apalutamide and enzalutamide. So understanding who is going to benefit from that systemic therapy, makes sense. And, in addition, you could argue, well, those trials were using conventional imaging, but obviously in STAMPEDE, I can't go back, but there was a clinical benefit even in the N1 or locally advanced state, people who may have been metastatic. And this is important because in well-done retrospective series in the meta-analysis, you could see that about 5% of patients with otherwise intermediate risk prostate cancer will have M1 disease. About 8% of patients with PSAs less than 10 will have M1 disease, and that gives them a lot of considerations. Many of those will be oligometastatic and likely still benefit from treatment to the primary, depending on how you interpret the STAMPEDE and HORAD data. But certainly they benefit from intensification of their systemic therapy. And then we'll move towards the biochemically recurrent and the quote-unquote non-metastatic castrate-resistant setting. Here again, you're going to make considerations for what kind of salvage local therapies you're going to use. Can you do metastasis-directed therapy? Should you intensify systemic therapy? And we're going to start with the biochemically recurrent setting, so the hormone-sensitive space. So what we know for post-prostatectomy is that salvage radiation is more oncologically effective if delivered at a lower PSA. This is just kind of the ongoing work from Stevenson's group that shows that as the PSA is lower, the biochemical-free survival and the metastasis-free survival is improved. There's still some patients, even at those low PSAs, that don't respond to therapy. And in the context of functional imaging, this all makes sense. This is a recent paper out of the UCSF which is showing PET PSMA performance. And you can see as you go towards higher PSAs, the chance that you're going to have extra prostatic, extra pelvic disease is increasing dramatically. So if you have everything at your disposal and you want to say, well, who benefits the most from salvage radiation therapy to the pelvis, which I could argue for prostate cancer may be more toxic than things like SABR to a metastasis, which we'll talk about in a second. Who are those folks? It's a small study, but well done by Emmett and colleagues, where they looked at men with PSAs below 1 that had a PET PSMA. They looked to see who was benefiting the most from the salvage radiation therapy in terms of disease response, with a surrogate being PSA-based endpoints. And it basically was if you were PSMA negative or you had PSMA uptake in the prostate bed only, those men had an 80 to 85% response to their disease. If the disease was already an N1 or M1 by PET imaging, there was only a 50% response rate. And so really people who have negative PET imaging or PET imaging in the prostate bed are the big responders, and there should be some real question marks about salvage radiation to the pelvis in the other cases. That same knowledge can transfer over to salvaging someone post-radiation, where the stakes might be arguably higher. We know for salvage prostatectomy and salvage cryoablation after radiation is that it's most oncologically effective if the PSA is under 4. And thank goodness, at least in my practice where I do a lot of both of these salvage cases, PET oxygen can help me stratify who might be a better candidate and who might not be, because there can be positivity at lower PSAs. So how about we talked about a little bit in Dr. Rowe's talk, metastasis-directed therapy. So what do you do with the person who, has a PSA recurrence, hormone sensitive, and you see that they have metastatic foci? The SABR Comet trial, which was a phase 2 trial taking all comers with low volume metastatic disease, showed a 13-month increase in overall survival if the patients of multiple tumor types were treated with stereotactic radiation to those METs. A prostate-specific study by Ost et al. Showed a statistically insignificant 8-month increase in overall survival, not overall survival, in androgen deprivation-free survival for hormone-sensitive, low-volume metastatic prostate cancer, as defined by PET choline. So now moving from the hormone-sensitive space to the castrate-resistant space, the same principles sort of apply. If we look first about intensification of therapy in the non-metastatic castrate-resistant space, we now have 3 trials showing that intensification of androgen therapy, directed therapy, increases metastasis-free survival. And that's not surprising because when you really look at the men with castrate-resistant prostate cancer with functional imaging, like PET PSMA, you find that the majority of them are indeed metastatic. Even more importantly, from some of these somewhat okayly powered study, you find that in the men that have non-metastatic castrate-resistant prostate cancer, 24% of them are recurrent in the prostate or prostate bed only. That means that 24% of these truly, at least PET non-metastatic castrate-resistant prostate cancer patients are candidates for cure and can come off all systemic therapy potentially. More so, in the men that do have metastatic disease on functional imaging that wasn't seen on conventional imaging, a lot of them had low volume metastatic disease. And building off of like Ost's trial is another recently published study with men with castrate-resistant prostate cancer who had low-volume metastasis, showing that stereotactic radiation could increase the METs-free survival by about 12 months. And if you allowed them to get stereotactic radiation, and then if they popped up with new METs but were still oligometastatic, allowed them to get more stereotactic radiation, then at 1 year, 72% were free from systemic therapy in the CRPC, from new systemic therapy in the new CRPC space. So we're going to get more of this in the following talks, but just to go over like some of the key points that I think about with PET imaging, again, before I get bombarded, not well flushed out by prospective randomized studies in any way, but one, I think that we can all say that PET imaging increases the accuracy of detection, both for clinically significant prostate cancer in the prostate, but certainly for staging outside the prostate. If I have a patient who's biochemically recurrent, hormone sensitive, and the PET is negative, or if they're castrate resistant and the PET is positive only in the prostate, or if they're hormone sensitive, it's only in the prostate, those are people with opportunity for cure with local treatments, and the local treatments can be done with modest morbidity in many cases. And then I think, and we're going to talk more about this in future talks today, but stereotactic radiation, there's a real evolving data there, and there's evolving data that it can benefit men both in the hormone sensitive and CRPC state. Adequate staging to really understand their disease seems to play a role in this, and PET imaging is allowing for it. Thank you very much for your time.